Ladies and gentlemen, can we warmly receive this dance? I'm not sure that was enough. Can we appreciate Nyanga Entertainment Troupe? Thank you very much. Ladies and gentlemen, it's indeed an honor and pleasure to be with you today as we officially open the conference, our 16th annual Open MRS Implementers Conference. We want to welcome you. The way things are done here usually is we ask, if this is your first time in Uganda, we want you to stand so we can appreciate you. I know the conference has been here, this is the second time. If your first time in Uganda, please stand. Stay standing so we can appreciate you. Your very first time in the Pearl of Africa. Can we warmly receive them, ladies and gentlemen? Welcome. Please take your seats. Welcome. Thank you for coming to the Pearl. Welcome. We say this is the heart of Africa. And if you look at the map of Africa, you clearly will see the shape of the heart. And the only shape of the heart is the exactly map of Uganda, right bang in the middle of Africa. You will find the happiest people in the world. You'll probably find the finest pineapple in the world. My worry is if I'm going to keep you awake after lunch, not after that heavy buffet. So hopefully I'll try and keep all of you with us. So welcome to this, the 16th annual Open MRS Implementers Conference here at the Speak Resort in Munyonyo. You couldn't have picked a finer place to meet and gather this year. Our theme, transforming digital health through open innovation and collaboration. And so we want to appreciate Open MRS and our local hosts, METS, and all the partners and sponsors for ensuring we're having such a successful conference. I want to, in a special way, to run through a bit of protocol, so you'll allow me recognize some of our VIPs who are here with us, and more specifically, our Ministry of Health, and the ministry is well represented. May I request the Ministry of Health team that are here to stand for recognition? The Minister of Health of the Republic of Uganda. Please stand. Paul and the team, everyone who is here, I know all of you are a bit mobile. Welcome. Can we appreciate the Minister of Health? They continue driving innovation in this country and they continue digitizing, or those of you in the IT space, a lot of you want to call it digitalization. So we're still struggling, those of us who are not in the IT space, to tell the difference between digitizing and digitalization and all this complicated IT language. Welcome. On behalf of OpenMRS, can we recognize Paul Biondich? Please stand for recognition. Can we appreciate him, ladies and gentlemen? And of course, our very own Dr. Alice Namale from METS. Please stand for recognition. We want to appreciate our friends from CDC Uganda. Stand for recognition. I know we have, yes, CDC Uganda. Thank you so much for joining us. And all our sponsors, you know yourselves, Axtute, Seal. Can we stand, our sponsors? Stand for recognition. I've seen Axtute there and Seal. Let's appreciate them. This would have not been possible. Another round of applause, ladies and gentlemen. All right, so a couple of things need to happen, and the screen had some QR codes. Very first thing I want to request, the QR code for the site visits. This is very important, and I know there's a QR code in front of you somewhere. It would be nice for you to register so we can be able to manage the logistics. So through the conference, let your colleagues know, those who are joining us, that you can use the QR code in front of you, and then you're able to register for and sign up for the site visit. That's very important. And we have our lovely exhibitors here. Find some time during the conference to visit our exhibitors. I'll be speaking to them. Of course, METS, JTOS, Axtute, and EPC Care. Please find some time and visit the exhibition booths through the day and through the conference. I want us to officially kickstart this conversation by inviting Dr. Alice. She will do the honors of making welcome remarks. Can we warmly welcome Dr. Alice, ladies and gentlemen?
When it works. So, good afternoon.
Afternoon.
Louder, please. Good afternoon. So, I've been introduced and I'm here to give a few remarks. Colleagues, friends, and partners, I do welcome you all to the OpenMRS 2025 Implementers Conference. In a special way, a warm welcome to the participants visiting Uganda, and they have already been welcomed, but just want to emphasize that I do hope that this week will meet your expectations and you'll be able to not only enjoy the technical aspects of the conference, but also enjoy our beautiful country. I do hope many of you can travel out of town. It's a very beautiful country, the Pearl of Africa, as already mentioned. Uganda as a country has benefited from OpenMRS products, which are open source. In return, we have also made our contribution to OpenMRS products, as you learned during the conference. As a METS program, which is hosted under Makerere School of Public Health, our legacy contribution is the Uganda EMR, which is currently deployed in over 1,900 facilities in the country, of which about 400 are actually running the EMR as a point of care, in which case they actually capture data at the point of service. Of these, many are high volume sites, about 700 of these, and many of them are adopting point of care. As you know, this will be very instrumental in reducing the printing requirements. Those of you who will be participating in site visits, as mentioned, will have the opportunity to see some of the remarkable features of this EMR and the milestones made in the implementation. So please do sign up. We have described lots of systems at the different facilities. Therefore, it's no surprise that we are hosting this conference with the theme Transporting Digital Health through Open Innovation and Collaboration for the second time. I am told this happened, I think, 2016, the first time, and I wasn't with the school by then. And I do thank the OpenMRS team for this acknowledgement to Uganda. As the METS program, we have also provided technical assistance to the Ministry of Health in the development of other amazing products, establishing functional registries, establishing a national health data warehouse, establishing interoperable digital systems, cross-border data sharing and learning, and capacity building for many health professionals, some of whom are here. As I conclude, I take this opportunity to thank the Ministry of Health for their leadership, CDC Uganda for the funding that we have been receiving over the years, and the implementing partners who actually maintain all these systems at the different health facilities, and of course, the health workers who use the systems. I do hope that you'll enjoy the conference and also have lasting memories of Uganda as a country. I thank you.
Surely that wasn't enough for Dr. Alice. Can we appreciate Dr. Alice, ladies and gentlemen? Thank you, Dr. Alice, for welcoming us to the PAL. Dr. Alice just stopped short because she knew I was going to mention that you need to ensure that you've had a taste of our Nile perch and tilapia before you leave. Please, if you haven't, ask a Ugandan friend to show you where you can find the finest Nile perch or tilapia. And if you are struggling, I would suggest you look up some nice fishermen just across the lake and just pick yourself one. That's even the easier part. And so you have a fresh one picked by yourself. But I have always been told that the digital teams, especially the IT specialists, are usually the worst fishermen. So you will need somebody who is not an IT specialist to help you pick up one. Allow me now invite our Executive Director of NMRS, Paul Biondich, to come and make his remarks. Ladies and gentlemen, please welcome Paul.
Hello, everyone. Can I ask everyone to take a quick second and stand up and stretch? Everyone stand up and stretch. We got to digest that lunch. Big stretch. And then I want you to do one other thing with each other. Talk to the person next to you and greet them and say hello. Just take a quick second. Oh, how are you? I, I asked you all to do that for a couple of reasons. One, I wanted to remind everyone that the reason that we're here is because of each other. This amazing community has been a real gift of my life, and I'm sure many of you in the room can say the same. This OpenMRS community has become thick in many of our blood. And I feel it's very fitting in some ways that it's here in Uganda. OpenMRS has a long, long history in Uganda that goes back many, many, many years prior to METS, prior to the ministry leadership that's currently in place. I remember there were days in where OpenMRS, some of the very first implementations ever, like in 2006 and 2007, were based in Uganda. And so it is maybe in some ways fitting that in this moment now, when everyone is having questions about digital health, that we all come together in one of the birthplaces of OpenMRS. I think we can safely say that Kenya and Uganda were two of the main places that OpenMRS started. And if you look at what the community is today, there's a deep spirit of OpenMRS through lots and lots of people here in Uganda. So I personally want to thank the Ugandan people, the Ministry of Health, and the OpenMRS community for all coming together. I know that in talking to many of you that it was difficult, a little bit more difficult to come this year, but your presence speaks so much about what we're trying to do together. I also wanted to especially thank the Ministry of Health for their warm welcome to us. Um, we understand that the responsibilities of digitalization are significant and large, but I think many of us within the OpenMRS community are wanting to live in solidarity with the ministry's goals. We're really excited to partner with you and meet your needs and expectations. And to the community members who come from around the world, I know that many of you come to OpenMRS because there are goals that you're trying to accomplish within your countries and your environments. And so hopefully for those of you that are new to the conference, you'll bear with us. Our methods for doing conferences are often different. You might have heard of the concept of an unconference. For those of you that are new, it might be different to you. But my advice to you is to think about what you're trying to accomplish this week, what you're looking to accomplish. And I can promise you that by the end of this week, hopefully your needs will be met and then some. And so please spend the time to get to know each other. I think you'll find a lot of familiarity in the problems that you all are trying to face. And I think there's an opportunity for us all to continue to collaborate and support each other because that's really, in my experience, the only way that we'll be able to move forward digitalization throughout Uganda and the rest of the world. And so I'm really personally humbled. I think I speak on behalf of everyone within the OpenMRS not-for-profit organization, which is small, that we're just very excited to have this event with you all. If I haven't met you, I personally would love to have the opportunity to get to know you. So please do make the time and pull me aside. And I will really try to make the time to get to know you as well. And so with that being said, I just want to welcome everyone. Thank you everyone for your participation. And I look forward to being able to speak with you all in the days to come. Thank you very much.
Thanks, Paul. Can we appreciate Paul, ladies and gentlemen? I am glad Paul started this. So when through the session, I keep asking you to stand. I will just say I'm following the cue that has been issued today. So I'll try and keep you awake through the next part of this session. Since we're speaking about digitization, and I'm glad both Dr. Alice and Paul have spoken to this and how the Ministry of Health is very open-minded, but are very proactive and continue to drive this conversation here in Uganda. We will now invite Paul Mbaka from the ministry, who has been at the forefront of this conversation. And I must mention, Paul, I was witness, even here in this room, when he was launching a similar agenda here with all the stakeholders, district health officers, district medical officers, Minister of Health senior team, and all the stakeholders in this sector here in Munyonyo, when he was speaking about the end of writing physical documents in the hospitals. And we've been holding him to account on this. So we want to invite Paul to tell us what they're doing and how they continue to support this conversation. You're very welcome, Paul. Can we warmly welcome Paul Baka?
Thank you. Thank you very much, Maurice. Uh, what Maurice is not saying is that he's our designated master of programs for all things digital in Uganda. So whenever there is any event that has a digital dimension, he's always ready to respond to our call. Thank you very much. And I'm sure the way he has been managing the program, there's evidence that he's been in these spaces for a while. My name is Paul Mbaka. I work at the Ministry of Health. I head the Division of Health Information. The Health Information Division of the Ministry of Health is responsible for both digitization of health service delivery, but as well as health statistics. I am here today on the behalf of the Director General of Health Services, who unfortunately traveled out of the country and couldn't be here with us. And he provided a speech here that I'll go through with all of you. So as I start, I'll go through his speech. I'll read most of it, but you will allow me to sneak in a few words of my own. So, good afternoon, distinguished colleagues. On behalf of the Minister of Health, it is my great pleasure to warmly welcome you to the OpenMRS 2025 Implementers Conference here at the beautiful Speak Resort Munyonyo. This is not the first time that Uganda is honored to host the OpenMRS Implementers Gathering. Back in 2016, we had a similar honor, and it was quite beautiful. So today it is a privilege to host you once again as a testament to Uganda's commitment to digital health and our status as one of the largest OpenMRS implementers in the world. It is important for you to note that as you are here in the Pearl of Africa, it was less than 500 meters away from this very spot that Winston Churchill marveled at the beauty of this country and gave it the name the Pearl of Africa, just somewhere down there. So during the break, please make some time and go and see if you can reach the same conclusion as he did. I would like to begin by expressing our deepest gratitude to the political climate that we enjoy in Uganda in terms of the drive towards the digital transformation, not only in health, but across government. This has provided a platform that has allowed us to explore some of the opportunities that are available to transform health service delivery in such a way that we can leverage digital tools to act as job aids to facilitate provision of healthcare. I also recognize the different partners and friends who are here today, and all of you participants who have made time to join this conference here today being hosted in Uganda. Over the years, Uganda has scaled OpenMRS deployment to nearly 1,900 health facilities, but mainly supporting HIV, TB, maternal, and child health. However, in recent times, there have been implementation, including in private, not-for-profit health facilities, that I have taken this beyond the scope of this very disease-centric area of work. The benefits that have accrued from our implementation of the OpenMRS has scaled from improving accountability, a better epidemiological understanding of the diseases and services that we focused on, but also provision of accountability in terms of programmatic accountability for the work that we've done. However, as we are here today, while it might always be nice to thump yourself on the chest, we should recognize that we are in a fast-moving ecosystem, and new ways to optimize how we use technology keeps presenting itself to us. And if you've taken time to observe what happens to digital tools that have been introduced in the world over the years, those that are most adaptive are the ones that have survived. Those that have taken note of the changes that have happened, the strides that the human race has made in the areas of digitization and incorporated that in implementation have survived. As we reflect on our successes today, the achievements that we've made over the years in the implementation of OpenMRS, it is important that we recognize some of these strides that have taken place. We are coming from a place where implementation of digital systems, quite understandably, were mainly driven by a data provision point of view. Can we provide data upstream for accountability, long-term planning, and the likes? We are now moving to a place where we would like these digital systems to act as job aids to clinicians, but also enable, I don't know if the word democratization is an overused word, but to democratize healthcare provision in such a way that our health clients themselves contribute to their management. And the OpenMRS must be open to these challenges. OpenMRS must be open to these challenges. We're also moving to from a place where, like where we were thinking like theoretical economists who assume that human beings are rational and they will only do rational things, but in the real world, we also do some things that are irrational. And that when we come up with these data tools and the information products that come with them, be they dashboards or whatever reports that they generate, that those who are supposed to make decisions based on this data will seek the data, interpret it, and make decisions. We also observe that this has been quite presumptuous of us. And it is important that the tools that we deploy facilitate synthesis and optimize access to insights. We should move to a place where the insights and the data comes to you and you don't have to seek it where it is. Because we have observed that our managers, while we want to assume that they are rational and will seek the data where it is, have not been like that. And instead of keep throwing at them the label of you are not digitally literate or that other label or this other label, it is high time technology itself covered this gap. And I would like to call OpenMRS to this challenge. How can you bridge that data use gap, which is basically caused by how convenient it is to access insights? Another important lesson is that data-driven management is a powerful catalyst for performance and efficiency. Detailed workload reports improve clinician attendance, as managers could base this on any reward mechanism that might be provided. The tools that we build should not only manage the patient, but they should also manage the people who manage the patients, so that we can equitably distribute workload, so that we can identify individuals that require capacity strengthening, so that we can require where we have HR gaps, because there are a few clinicians that are being overloaded. And this all calls on us to move away from what we used to do in the past, where we were using tools like OpenMRS only from an accountability point of view, to converting it into a job aid that will facilitate. Of course, OpenMRS is at the heart of the moves towards integration. The problem with integration is that we have used it even at the point where we need to unify user experiences. It is not always enough for systems to exchange data. Sometimes we have to build these systems in such a way that they are pluggable and they can connect to each other, so that users of those systems have a perception that they're in the same place the entire time. This would require all of us to stop having a siloized mindset and think more broadly on how we can build systems that could exchange data when data exchange is required, but can be fused together and plugged to unify user experiences when we are targeting the same user. With these words, it's my official, it is my honor and pleasure to declare the OpenMRS 2025 Implementers Conference under the theme Transforming Digital Health Through Open Innovation and Collaboration open. Thank you very much.
I think, Paul, before you go too far, I'll invite you and Dr. Alice and Paul Paul to come. So Mbaka, please come. The Paul and Dr. Alice, please come. So you can have the very first photo here. I'll invite a representative from CDC to come and join them. No, it's a photo, sir. So you're not sitting yet, sir. No. I know you like sitting, but it's a photo. Can we use the top? Cameraman, you decide. They want you up here. Baka, they want you up. Can we appreciate the Director General? Paul was acting on behalf of the boss. The conversation we are having today, as Mbaka said, is very critical, and I'm glad that the Minister of Health is spearheading this conversation with partners. And that's why this particular photo is very clear. You have policy with partners, both implementing and development partners. And so this is the right conversation to have. And we want to appreciate all of you. Thank you so much. So you could take your seats. Can we appreciate all the key stakeholders, ladies and gentlemen? I think, Paul, you need to stay. Yes, not Baka. This is the Paul. Please take a seat. Feel free. Any of the seats are available. We are now transitioning into our panel session, and I want to quickly invite Kenneth Musenge, Health Information Systems Team Lead at CDC, to come back. We also have Jamir Mpima, who is speaking on behalf of the team at the Ministry of Health. Jamir Mpima is a digital health specialist at the Ministry of Health. And also Jonathan Pango, data science and informatics lead, METS. And yes, we have a fully constituted panel. All right. So this is going to be extremely conversational, nothing heavy, and we want to allow for this to be an open session. So at some point, we may allow you to ask a question or two if I'm managing my time well. But colleagues, we have 45 minutes, and so we'll need to manage this time very carefully because we are clearly speaking to a matter of interest, but we don't have too much time. So allow me begin with Jamil, who is going to help set the stage for this particular conversation. And we want to talk about what it means for government to act as a digital health catalyst. Just want to check that the mics are working. Just check. Yes. Excellent. Yes. Um, Listening to Paul Bakker, it's very clear the Minister of Health is spearheading this conversation in the right direction. But what does it mean for government to be the digital health catalyst and spearhead this conversation?
Thank you very much, and good afternoon, colleagues. I also take this opportunity to welcome you to Uganda, the Pearl of Africa. Jamil Mpima is my name, from the Ministry of Health. And as already said by Paul, digital transformation is something that is a process. And in that process, you require, in most cases, lots of resources to set it up and also to run it. So you find that in most cases, tools like OpenMRS and other open source tools, for them to be implemented at scale, you require lots of things regarding infrastructure. That is, you need computers, laptops, and so many other devices. You need, connectivity. You need to do lots of training for the different users, and all those require resources. So government comes in as a catalyst to convene the different stakeholders, but also put in place the right ecosystem. What that means is that government will set the standards of which these systems need to work. It will set in place an ecosystem where these different systems are able to talk to each other. So OpenMRS is able to report, send reports to DHIS2. You have, some SMS platforms that are able to communicate to OpenMRS, and these are working like the community. So government now comes in as a catalyst to make sure the different players come together. Right from national level, we have CDC as a donor going through, the implementing partners who are at ground level, but also the districts and the health facilities that are actually using the tools. And then the other stakeholders also come on board to make sure the ecosystem is complete. Thank you.
Paul, I want to bring you in here because we have always known government to be, and he's mentioned the critical challenges that they have in digitizing health services, but we've always known government plays second to the private sector, that the private sector is always running with digitization, with, opening up spaces for services to get to the people. We've seen what the telecos are doing in different markets on this continent. And that's the question we keep asking. How can we allow for a ministry like Ministry of Health to begin looking like a private sector led policy implementer or policy maker? How do you drive that and energize them to do even better?
So I might respond in a couple of ways. One as a pediatrician, and one as someone who has witnessed that in the United States where I'm from. And I'd make a couple of comments. One, as a pediatrician, maybe to Paul and Baca's point earlier, when he talks about the medical record system being a job aid, it actually brings me great joy to hear that, because I think the OpenMRS community has always imagined the medical record as a system that improves the quality and efficiency of care. And so if we think about that from a pure business perspective, increasing the quality and efficiency, ultimately efficiency reduces costs and creates a more productive system. And so then the question is, how do you build an ecosystem, a sustainable ecosystem around that? And what's the ministry's role within that? Well, in the United States, if I could be very frank, they didn't till the field appropriately. So, like, if you look at the city of Paris, you can see that it was a well constructed urban plan. The city, there was meaning around how the roads were built and the city was designed, and it's very beautiful. When it comes to digital health in the United States, they didn't do a plan, an urban plan that lays out the rules of engagement and how different stakeholders are to participate. And I think we suffered as a result in the United States. Right now, data integration and interoperability in the United States is a way that companies make money. And from my perspective, that's not necessarily the most healthiest model. So I do think that there is a world in where a country that has strong leadership like Uganda can lay out a plan that designs data integration as part of an expectation for engagement and can incentivize a business ecosystem around that. And I think one of the dreams that we've had for projects like OpenMRS is that we could lower the total cost of ownership and the risk around implementing record systems for countries like Uganda, because through an open source model, you can share the risk and responsibility of the software development amongst many participants, which makes it less risky for a ministry to engage. And so I think there are ways that you can build for-profit even ecosystems around an open source platform. But I think it requires a really fulsome understanding by all of the stakeholders in the country as to what the ministry expects and where the business opportunities can be derived, and you want to protect against places where it shouldn't be. So, like, for example, we shouldn't incentivize businesses to make interoperability a place that can make costs. We should do that around the quality of services that are provided around the implementations themselves. So there's a lot more I can say around that, but that would be how I would first respond.
Thank you very much. I'll come back to you because you highlighted something there that I've found we've done very well here in Uganda with the health structures, because you have the non-profit organizations that are operating extremely very well, but then you have the private sector that is extremely very commercial, and there's a lot of challenges we have in that space for the local Ugandans. But also, you have the Minister of Health that is now championing, a bottom up approach that is allowing for the data coming all the way from the health centers, whether it's 2, 3, all the way up to the Minister of Health, which is a great system that they have put in place. But I want to come to Jonathan, because we're now going to talk to, and I'm glad Paul has started the conversation on how do we build on the private public partnerships and collaborations, because that's what we're going to be talking about through the conference, to be able to leverage on digital health systems. How do we begin this conversation?
Thank you very much. I'll start from the point of seeking care. If you look at Uganda setting, care is being taken or received from both the private and the public. And as Minister of Health, I think they have created a very good, conducive environment that caters for both parties, both the private and public. Giving an example, when Minister of Health was establishing the compendium of guidelines that were going to support the country in implementation of health information systems, one of the compendium, one of the guidelines in there is the health information exchange. During the formulation of those guidelines, Minister of Health sought consultation from both the public and the public sector. And all together, we came together to ensure that these are created, launched, and implemented. Right now, as a country, we have a very good live example that we are using, the one for supporting health information exchange using viral load exchange. All the way from the facility to the center, test orders and results are sent through this exchange, which is being guided by that policy, which was contributed to by both the private and the public sector. So inclusion of both parties, I've seen this example by the Minister of Health, has led the adoption of digital health initiative very easy in the country, which is being accepted across all the cascade from health facilities, which are the primary users, to the policymakers that are at Ministry of Health level.
Kenneth, same question. The private public models that are working for us, and how can we leverage on those that are already working to actually build up on the existing platforms?
Thank you, Maurice, and good afternoon, everyone. Like you've heard, my name is Kenneth from the U.S. Centers for Disease Control here in the Ugandan Embassy. So right now, those partnerships, the private-public partnerships, have never been important, actually, more than a time like now, when we see or when we are seeing that actually most of the resources, most of the funding, most of our innovations in the countries have relied on, even within the Ministry of Health, are largely through donors. But as you've seen, you know, the funding is going down and going down, and it becomes very important that some of these innovations that have been started, this seed that has been sown by these resources, for it to be sustained, then it becomes very important that we have to innovatively come up with better ways. And one of them actually through the public-private partnerships. So, and there are so many ways this could be done. And Minister of Health has tried to do it here in Uganda. So let's look for the case of infrastructure, like Jamil mentioned. Like there's quite a lot in terms of infrastructure that is needed, whether hardware, connectivity, and whatever. So some of these things are not really done best in the health sector. The people who bring the best infrastructure, whether it's the telecoms, whether it is power solutions or whatever, are outside this ministry. So it becomes very critical that if you're really going to succeed, for instance, if you take an innovation out there, and how our situation looks in Uganda, that the largest chunk of services are in, at lower level facilities that tend to be semi-rural or rural. So even if you took these innovations out there and then there's no internet, there's no power, okay, then you're not going to get meaningful use of, or you're not going to get the full capability out of these innovations. So it becomes very important that for you to put, for instance, the infrastructure in place, you need some of these partnerships. You need to partner with, the people who can bring some of those capabilities best, and, see how you get into negotiations or memorandum of understanding that they bring it to you at a cost which would not be the commercially up, the commercially approached one. So it becomes very important that these partnerships are also important. But I'll also give an example. For you to succeed with these innovations, you need the workforce. You need the trained workforce. So I bet most of these people who've been here have probably benefited from special trainings, or they've invested into themselves to bring themselves to where they are. But creating those partnerships, for instance, between a ministry and a learning institution as part of workforce development, and embedding some of these, the learning, the skill sets that are needed, and putting them into, creating a collaboration with other institutions, that are private. They could be private universities, private institutions, as, a vehicle for creating your workforce. Get students to come and volunteer, so that they are molded into the kind of people you need. I could go on and go on, but what I want to emphasize here, that these private public university, partnerships are very important, to be leveraged, especially by the government. Thank you.
Jamir, to pick up from that, is there one such example you want to give us here in this room that is actually working and working extremely well that we can pick up from?
Yeah, so we have lots of those private-public partnerships. For example, picking up on the equipment itself, we have had several contributions of equipment from the private players who, as a part of giving back to their customers, they try to install these systems, rather the machines within the facilities. But also, we have the PNFPs who also contribute in trying to make sure that there is support that comes in to make sure that these softwares run. And they also contribute as part of the community. So these may not really be paid, but they come in and make their own contribution. The telcos, like we have mentioned already, have also made a big contribution. For example, we run a community health system which has over 18,000 users. And so you find the telco gave us a tool where they're able to synchronize their data with Ministry of Health, and they don't have to really pay for that airtime or to pay for data. So that is already a contribution. Those are what I can mention for now.
All right. Thanks very much, Amir. I want to come to Paul, and then I'll also turn to Jonathan. Kenneth touched on something, the current funding gaps and the challenges we're having in the health sector. It's not just here, it's across the world. We know what's happening. Um, I want us to speak to something called the non-monetary levers. What are the things that, for example, the Ministry of Health and partners can begin implementing that don't necessarily get affected by the cuts in funding that we are currently seeing across the health sector in the world? And I know Kenneth is he's one of those who's frustrated.
Well, what I can say is that underneath projects like OpenMRS and others are a lot of opportunities for people. And a lot of people ask the question, how did OpenMRS get to the place that it is? And they make an assumption that it was built through a lot of centralized investment, a large development team. But the reality is actually quite different. OpenMRS has been built by a collection of people who have collaborated. And oftentimes they collaborate for reasons that are of self-interest, like they want to build a business around medical record systems, or they want to learn the acts of medical informatics. And there are a lot of incentives that the ministry and stakeholders within a country can use to motivate action within an environment. So, for example, at the McCary School of Public Health and McCary University, there are lots of students who want to understand what does it actually mean to do digitalization within a country, and they want those learning opportunities, but those learning opportunities can be double-sided. They can be an opportunity for a student, but they can be a development effort that contributes to something that has value to the country. And so I think thinking creatively about what different motivations are out there for people has been really powerful within the OpenMRS community. A lot of people volunteer their time because they simply want to contribute to something that has meaning and value in the world. And I think, in many cases, Ugandans want to participate in the development of their health system, but they oftentimes don't have a way to meaningfully do so. And so the ministry could create those opportunities for people if they wanted to leverage that. I think there's a lot of ways to motivate action. And I think a lot of people here in this audience they probably resonate with what I said. They're here because they want to help their country, and they have participated oftentimes in a collection of organizations over a long period of time because they have a mission orientation. And I think the government should understand that, embrace that, and leverage that opportunity and make those opportunities available to their people. So that's my thought.
Excellent. Jonathan, similar question. In this era of, diminishing funds, who do we turn to, or what do we need to do so we can actually continue activating digital health?
One thing that we have been able to achieve, mainly from the past when we had some resources coming through the donor funding, was being able to build in-country capacity. Now, as resources are going down, at least countries are not left at zero. There is in-country capacity that has been built. Take an example. Many years back, we spent a lot of time implementing digital health solutions. All right. And these were established at facility level and also at national level. Uganda as an example, we have a community of practice, people that have gained skill sets to ensure that we support integration of systems. I think last month there was a capacity building training on fire done by Helena, and I saw a lot of Ugandans joining that training. Right now, this is a pool of expertise that can be encroached on to support integration, ensure that you have systems like the EMR, which is at facility level, integrating with the DHIS2, which is at national level, to support reporting. We'll take another example, academia, Mackay University. Biondich was talking about Mackay University. They have introduced digital health courses, which are also aimed at building capacity of locals to ensure that they can come up and support in the digitalization cause. Now, as resources are going down, at least this is something we can anchor on to ensure that we sustain our systems despite the cutting of resources.
Excellent. Jamil, let me come back to you. And this time we are asking, what are you putting in place as a ministry and working with different MDAs to better coordinate the coherent national digital health agenda? What is it that you're now doing as a ministry to support the coordination, the interagency coordination, so you can actually deliver a better digital health agenda?
Yeah, thank you. In the Ministry of Health, we pushed for what we call Interministerial Data Committee. And so this committee, we had to let it be hosted by the Office of the Prime Minister, which is the coordinating ministry. And so this committee sits every 2 weeks and has all the relevant ministries that are coming in to solve some of the challenges that we have been grappling with, especially when it comes to digitalization agenda. One of them is financing, definitely. And out of this committee and through the leadership support, we have managed to mobilize some resources. At least within this coming budget, we know that at least some $2 million have been set aside to support the digitalization agenda. Two, we usually grapple with digital literacy on the user end. One of the shockers to adoption is usually that how do people know how to use a computer? And in most cases, the answer is not very amusing. So we have called on Ministry of ICT to also come in to support with rolling out digital literacy programs, specifically targeting health workers because that's where our market is, but also the general population, and at least this was already fitting within their programs. Power is a big issue, and we have called on Ministry of Energy to also come and play a role when it comes to making sure we have stable power, we have clean power, we have other mechanisms of making sure that health facilities have flowing power that really never gets off. We are bringing in the private sector. Ministry of ICT and Ministry of Science and Technology usually play a big role when it comes to innovations. So we are tapping onto their expertise to make sure they support us in coming up with more innovative ways of doing things. But also, there is a member that we have been looking at, the Attorney General, to advise us. For example, we want to rethink of how we are implementing systems. Traditionally, the model has been that government pay, donors pay, and but how might we decentralize that particular aspect for these information systems, for example, like OpenMRS, to be a base of the health system which it thrives on, and through it we can be able to monetize some of the products that can be used to finance the health system, but also later a small portion goes to finance the systems. So that sort of needs a legal backing and some laws to be put in place. And so we are having all those players also come on in place. Of course, Ministry of Local Government is where most of the action is happening, because most of these facilities, almost all the lower level, are being managed by Ministry of Local Government. They're also coming in to make sure we now look at, the cost and benefit. Originally, we have been running a lot of paper-based system in majority of the facilities, but as we see now, the register, a single register, those who will go to visit the health facilities, a single antenatal register used to cost about $2. Now it's at $20, and it's still growing in size. And the big facility can use just one register in just 2 days, and that's a big patient volume. So it means that you have to keep buying those registers. So as you look at the paper, it is cheap to implement, but in the long run, the cost just grows. Vis-a-vis digital health, where you are having maybe a high capital expenditure, but which goes down over time. So we are looking at also Ministry of Local Government to encourage districts to be able to set aside a budget that can also be able to support the digitalization agenda. But also the private sector is not left out. We are talking to all the big players, at least all the big companies that we have seen. We know they can also come in and really make a big contribution. Most of the telecoms drive innovation. Most of them encourage, to put in place an ecosystem. Because if we are to, for example, exchange data and information between systems, you find that you need lesser connectivity. So the telecoms have to come in place to put the required infrastructure. URA, the revenue authority, is also not left behind, because it manages, the non-tax revenue that we generate from facilities as a collector. So how can they also bring their expertise on board to make sure they support the ecosystem? So those are what I could mention, but a few.
Thanks very much. And Paul, this is where I want to bring you in. When you speak about coordination for a coherent national digital health agenda, there's no one size fits all. What are the recommendations you'd make? Because now you're speaking to Jamil right next to you, that they, as a Ministry of Health, need to be looking at to better support the coordination that he has spoken to. And clearly, they're doing quite a lot. But how can we do better?
Well, the first thing I would say is that the Ugandan leadership understands Uganda better than anyone else. And so I think, in my experience, if I could be frank, a lot of digital health strategy was more externally kind of influenced than internally driven. But I see that really starting to change, and I would strongly encourage the ministries to take true control of that. And what I mean by that is that information systems are kind of like the nervous system of the health system. It's the it's the centerpiece of everything. And so, from my perspective, the first recommendation I would give is truly take that responsibility very seriously, because it has long-term implications 20, 30 years from now that maybe aren't really fully appreciable now, but they over the long run are. And so I think the Ugandan socio-political technical milieu is going to be very different than Kenya's or Rwanda's. So, like, for example, in Rwanda, they might want more of a central engineering team because their technical capacity might be different than here in Uganda, which might benefit from more of a commercial ecosystem. And so they understand the dynamics of their country the best. I think they should understand the stakeholders and what motivates them. But the other thing that I would say is that, as Paul described in his notes, he has a very clear vision, and I think on behalf of the government, as to what a medical record system should do. It's not a system that has a primary purpose of monitoring and evaluation. It's a primary purpose of improving the quality and efficiency of healthcare. And then there are secondary uses of the information system for monitoring and evaluation and other sorts of things. And so being really clear about that, and most importantly, setting the market expectation that that's what the primary goal is important in and of itself. Because to be quite frank with you, a lot of countries have not mistakenly, but they've they've under appreciated what a medical record system, for example, can actually do. They call it a medical record, but really what it is a monitoring and evaluation system. And so that's okay, but I think what really affects change around that is a government leadership setting an expectation and holding people accountable to that and constantly reminding them of the importance of that, which will drive the stakeholders at the private level to focus on clinical care, quality improvement, showing the cost benefits of these systems, demonstrating that, and driving a different kind of agenda. I don't know if what I'm saying is making sense.
You make a lot of sense, and that's really why I had wanted to ask CDC and Jonathan here to say something. But Kenneth, more specifically, I mean, when we speak about coordination, CDC would know this even better because with the amount of work you're doing globally under the USAID program and all the other US health agenda globally, coordination is very key. But when you speak about national health data systems, what else do we need to speak to that will support the initiatives under the Ministry of Health?
Thank you so much, Maurice. So I think to me, the most important thing that the government needs to do is to just stop being a gatekeeper. They need to take charge. They need to create the garden, where these innovations are going to thrive. But most importantly is the governance bit of it. They need, I mean, Paul and his team alongside Dr. Diana Twine, Jamil and others have been trying to do a good job, trying to make sure that, they take charge. We are talking of a space which is Minister of Health space, but for a very long time, it's been it's been full of so many players, and it's like the players were in charge. I mean, including us, and I'm not embarrassed to say this. So for me, the ministry rising up and trying to take on the governance role and taking charge and make sure that, they want to set the standards, they want to put, procedures in place that make sure that when you come into their place, it becomes very important. Then two is the coordinated investment. You remember Paul in his remarks did mention that, this mindset of siloed things, like, you have something thriving in Ginger, another innovation somewhere in Kampala, or in Kampala, 10 of them, another one somewhere in Karamoja. And oftentimes you don't even know who is brought it and what they are using it. So the ministry, taking on that, you know, and the sum total of what everyone is trying to do out there would probably be a good job. But somebody goes and takes some money to do something small, and another and takes a small piece of money to do almost something similar, but in a different way or in another place. So the ministry, through the different technical working groups, beginning to coordinate those investments and saying, yes, we appreciate, but our need is probably in this area. So if you're trying to support us, then kindly come together and we do this. But the other thing is what Jamil has also just mentioned. Um, the ministry beginning to include some of these things into their planning and budgeting, and not just waiting that, somebody else is going to do it for them. As in, what I'm trying to communicate that it's very important, and they've started on this. They are being intentional about it to make sure that, aspects around digitalization or digitization are a funded priority. So to me that becomes very important that, when there's coordination of investment, strengthening the governance, working on innovative ways of financing and saying, yes, well, $2 million is not too much money, but we've started. Previous, I mean, they could not even sit and say we are putting $2 million into our budgets. But to me, that is a good, smart move of beginning to see. So there are lots and lots of things I'll talk off, but the most important thing, centers around governance.
All
They
right.
have to take charge so that the rest align.
All
Thank
right.
you.
Jonathan?
May I just add on and say that governance with consultation. It is one thing being in a steering wheel and you make decisions by yourself. Now, this is something that I've seen our current Minister of Health doing. Although they have the powers to make decisions, They're always calling us for meetings. They are calling various stakeholders, consulting from them, getting their thoughts before they make their final decisions. And when they bring us together in one room, we discuss, they go back and make decisions, which we can also own because we contributed to them. So governance with consultation, it's something that I'm seeing working for us in our sector.
All right. I'll open this up, but there's the one elephant in the room, and I know we've touched it, the issue of funding, and the funding models. Maybe Paul, I need to begin with you. We've spoken about the non-financial levers, the non-monetary levers. What about new funding models? I'm sure you've heard about health insurance in Uganda, and how that is not necessarily working yet. Maybe we start there. Then I'll ask if there is a couple of contributions from the floor. Go ahead.
Well, I might start by just making a couple of observations, and that as a pediatrician, and I might be biased because I'm also a geek, but I think that health is an information business. I want to say that again. Health is an information business. The whole process of delivering care, it requires at its center information management, understanding information about a person, using information to make decisions. And so if we're providing health, then we are managing and working with information. And so the question for governments becomes, in a world in where there might not be historical financial support, what did they do with that? Well, the question then becomes one of efficiency. Like, how do we do more effective information management for lower cost? So that then takes you down the pathway of thinking about something like total cost of ownership. So what are we currently doing with information management in our country? What value are we getting out of that? What does digitization add on top of that? What new efficiencies and opportunities does that create? So one of the things that, to be very frank, I think that we don't talk enough about is that the as a ministry starts to get um, thinking about something like a medical record system as a job aid, and it has the primary use of clinical care, then that data, if collected in the right way, has the potential of being used in secondary ways for all kinds of uses. And that data has value and it belongs to the country and its people. And the ministry could think of any number of ways in which those data could be reused and made valuable to other stakeholders, right? So, like, for example, I mean, again, I'm going to may say something provocative here, but there are lots of organizations that probably want to understand more information about the health of Ugandans. The Ministry of Health should have the ability to negotiate with those stakeholders because those data have value. And if the country is going to be investing in the information infrastructure, they should be able to benefit from the outcomes of that infrastructure. And that oftentimes comes down to some of the secondary uses. A lot of the ways in which information systems are financed is making sure that all of the stakeholders that might benefit from the data have a contribution to the costs of the infrastructure over time. I think that's something that we often don't think about. We think about a medical record or an information system as something that has a cost, not thinking about the efficiencies that it creates on the other side. And you should think about those investments in that larger context, I think.
All right. Quick interventions. I'm happy to take two. I only have 8 minutes left of my time. And I will be glad to just, it doesn't have to be a question. It could be a contribution to any of the questions we asked. Yes, keep it short so I can take, and I'm very gender sensitive, so I'm glad it's male and female. All right. Go ahead.
Okay, thank you very much.
Introduce yourself.
Thank you very much. My name is Kevin Oyowe
Yes,
from
Kevin.
GHI Kenya in Nairobi. So I have just a couple of questions. First question goes to the government officials.
Jamir.
Yeah. So about ownership of the EMRs that we develop. So how can the government ensure that the systems that we've developed with donor support are not abandoned, but instead are absorbed
Yes.
into the national infrastructure, because we have lots of them that are getting lost in the process. There was a research grant somewhere. The outcome was perfect. And then the funds ended. The project folded. The system was there. And then all of a sudden it is not there anymore. And then my other question goes to Paul. We talked about the interoperability. So you mentioned that the United States did not have a structure before, and we all know that we are all in the same situation here, even worse probably. So so regarding that, um, how does how can we possibly accelerate this interoper interoperability to make sure that or how did at least or how is the United States government doing it currently? Yes,
All right.
thank you.
All right. Really brilliant. Please give him mic. There's a lady there. She, I always struggle with the question, your question, Paul. That word he mentioned at the end. I struggle with that. I come from a part of Uganda where the R's and L's just don't allow to work together. So I would never use that word. I would always find a way around it. All right, go ahead.
Thank you very much, Maurice, and the team. My question is also to Jamil.
Name?
Maureen Choncho.
Yes, Maureen.
Yes. So Jamil, my first question is more related to what he actually asked. What is the fate of OpenMRS in Uganda? Now that we know that mostly it's been used in facilities where there has been funding, but now it has reduced. Is this a system that is going to continue? And if yes, we understand that we've had instances of where you have a disease like TB and they come up with their own system. You have an OPD section and then you have their own system. But if you look at OpenMRS, probably it has the most coverage in the country, including at a lower health facility level. And yet we know that with the versions that have kept evolving at the moment, you can actually just build onto that and it can actually serve the entire healthcare system in the different facilities. I think that is it.
Thank you very much. All right. I don't have too much time. So Jamil, or you want Paul to start? Feel free.
Thank you very much for the questions. I guess both are related. Ownership of systems that are donor funded. Uganda has a famous map that was published years ago, I think by colleagues from UNICEF, which is titled pilotitis. Pilotitis was termed as a disease where we would have lots of pilots that would never go to scale. And most of these pilots came from donor funding. So as much as that map annoyed so many of us Ugandans, but it brought about some lessons that have been learned over time. To the extent that even when the USAID stop work order was announced, the effects that we have felt more or less to expand, but not to maintain what we already have. So what that means is that we had already put in place measures to make sure that however much implementing partners we are supporting, systems like Uganda EMR or OpenMRS, we had to match that support with, let's say, a facility counterpart who would take on, the roles of the systems administration, training, and the like that were needed. So as the funding cuts have come in, we have had to come up with a more rushed transition, if I may call it, for lack of a better word. Because initially the transition was, slow in nature. Some components are handed over, while others are being managed by partners like that. But now it has to be accelerated to make sure that at least Ministry of Health is able to run the source code. We support from the community of practice, like Jonathan mentioned. Ministry of Health is able to manage the actual rollout and expansion of the systems compared to when we would depend on the various roadmaps of the partners. So now it's Ministry of Health that is saying, okay, we need to push to these more facilities, but also to make sure we mobilize resources to carry on the work that has already been started and also push forward the investments that have been put. But most importantly, what we are doing is a lot of harmonization, a lot of reorganizing, a lot of, capability building as an institution. Because as Minister of Health, we have realized, okay, as we are bringing on more load, especially when it comes to the digital systems, we have to review our structures, the staffing norms, the staffing structures, right from MH till the lower levels, because you find that most of the facilities don't even have IT officers, and we are running on records officers whose training is not really technical in nature. So how might we convert those into more positions that are going to support the digitalization agenda? The capability improvement to make sure as we are taking on these systems, we're able to build onto them, but we are also able to support them financially and also able to keep them running through the efforts. What is making us comfortable and not worried is the team we are seeing in this room, because there is a big community of practice that Jonathan talked about. And most of these guys, because ministry may not hire a lot, but is able to command and invite you. That consultation Jonathan talked about, that we say, okay, we need to do these changes, and we put out a call, and different people will come and volunteer their time to actually do such work and be able to improve the tools that we have and make sure they are able to evolve like how we are envisioning them to evolve. Thank you very much.
So the question was around what advice I might have around how to do it differently than the United States, I think was the question when it came to interoperability. And maybe just to use a quick euphemism, in the United States, we built the homes first wherever we thought they should be plotted on the land, and then we thought about the roads and how they should connect to each other versus thinking about the roads first and then putting the houses on. And what I would say is that uh, I think that the concept of interoperability is oftentimes either grand and hard to conceptualize. And sometimes people try to build a beautiful interoperable architecture and spend many years on it, and they fail because the health stakeholders in the country don't necessarily understand to what problem it is a solution. It feels like technology first. um, so I think my main advice would be, given all of the experiences I've seen in countries, is that the Ugandan people should understand to which problems is data sharing necessary solution, and realize that interoperability is not a product that you implement and interoperability happens. It's really a human coordination problem to which technology is a solution. And it's an ongoing process. And I think it's one that is catalyzed by an initial activity or two that has clinical relevance and healthcare relevance. And it helps people understand how architecture can be supported, can support lots of different uses, and it's incrementally developed over time. And so, one of the biggest challenges I've often seen for countries is going from the concept of an architecture to the practice of an architecture. And I think oftentimes when I see countries become unlocked and move forward is when they decide, for example, that we're going to start with something like pregnancies, that we understand that there are issues of mothers over the course of the 9 months of their pregnancy, and we want to integrate the information from community health workers, clinics, and hospitals, because it's really the consolidation of all of those stakeholders that help a mother have an effective pregnancy. And that's just one of many examples of data integration that is concrete. It can speak to a health leadership in a way that helps them understand interoperability, and it starts to help the environment understand what are the pieces and parts that make data integration work. And once you have those examples, you can catalyze and build upon it more and more layers, to where over time what you end up with is an interoperable architecture. And so I think oftentimes what happens is either people build systems without thinking about the integration. It's kind of like a second thing that they realize afterwards. And I don't think that when you say Uganda's in a worse place, I don't actually agree. I think it's a fine time now to be having those conversations. But on the flip side, you can go the other extreme, and I've seen countries do this as well, where they say, we're going to build this beautiful architecture. We're going to have these consultants come in, draw these very fancy diagrams. We're going to spend, millions of dollars building out an infrastructure, but it doesn't actually solve any kinds of problems within a period of time. And then the ministry is like, well, it's hard to politically stand behind this because it's not actually solving any problems for us. So you need to have a vision in mind, but you need to start with a real problem and use it as a lever that helps make it real for people in a concrete way, which gets political traction, engagement, and further momentum around it. I hope that makes sense.
All right. Thank you very much. I want to ask that we wrap this up. So I'll begin with Kenneth here. Quick takeaways. How do we accelerate digital health systems? Microphone.
Thank you so much, Maurice. So the acceleration is going to happen in a couple of ways. One is that the initiatives, the government has to put an environment in place that helps the innovations to thrive. I don't know whether I saw it in India or where they've put sandboxes,
Yes.
where people who can't, acquire the platforms and the technologies to experiment on things can actually just use those things free of charge. That's one. Two, another way for which to do it is that the ministry has to put standards in place to make sure that whoever is coming into the place finds proper guidance and expectations of what should be done. Three, like I mentioned, is that the government has to be intentional, that even when donors are providing some resources to, kind of catalyze, then, like we mentioned, they have to be very intentional in terms of planning for these resources and making sure that they have the resources in place to take these innovations to scale.
All right.
But most important also is the workforce. The workforce, there's got to be a strategy put in place for needed to run all these innovations. And then putting that aside, what I wanted to mention, which no one was mentioning about while we're talking about this issue of the funding gap narrowing and everything, I think what is going to make these innovations thrive and stay out there is when the innovators create solutions that are solving everyday problems. If we are putting innovations in place that have the person who is getting the service doesn't feel while it is there, then it's going to be a problem to make these things scale. But if people make innovations that are going to address the problems of the common person,
Yes.
trust me, even when we ask for a pay from them as part of the sustainability agenda, they will pay. I mean, I'll give an example. You all know this mobile money on our phones. I keep on telling people that using mobile money is actually a very expensive venture to a common person.
Yes.
But do you know why right now it is one of the biggest channels where the biggest chunk of money goes? The local person on the ground appreciates, the ease, the convenience, and everything, that even you tell them that if you withdraw your 20,000, I'll take your 2,000. They can afford to pay that 2,000 without because it is solving their problem. So imagine we put an innovation out there in the community, whether for health assistants, the community health extension workers, the health assistants, where they saw value. They're not just looking at this as something to collect information for the government or for anyone else interested, but something they use, get somewhere, probably clients match their fingers, they identified quickly, they are given a service quickly, and so it helps coordinate the care, it helps the decision support and everything. When everyone starts seeing the value of that, then the resistance, because it's one thing the innovations to be in place, but what Jamil didn't tell you, there are healthcare workers who don't want to use these things.
Yes.
And whatever, because they just see no importance and value. So it becomes very important that we have to put the incentives in place to make sure that these innovations we are taking out there, people are attracted to them. They see value in using them. They don't look at them as ministries, something, funders, something. So to me, those are really my parting ways that we need to sort the governance issues. We need to rethink the financing models. Because imagine she's just talked of Uganda EMR and built off the OpenMRS platform in 1,900 sites. Right now, it's at risk. Okay, so we need to rethink also the financing models and begin to appreciate that probably the sooner the ministry opens up to this. I think they've had challenges even with cost sharing, even for health services and something. But um, sorry, it becomes, sorry about that, it becomes very important that let's do that value add that will make whatever we are trying to do very attractive to somebody, that even if they ask to pay for a small fee for a certain services, they will not complain, and that will make it easier to sustain this thing and scale it. Thank you.
Thank you very much. Jamir, you don't have the same amount of time. You've been hogging up most of our time this afternoon. So please keep it short.
So I think I'll end where we started from, government being a catalyst. So the role of government as Minister of Health, of course, is not just about money, but making sure we set direction that all players will abide to. We make sure we put the tools in place that innovators can plug into and be able to contribute, and then make sure the ecosystem is favorable to everyone to be able to act, and the ecosystem is self-sustaining in nature. Thank you.
Thank you very much, Paul. Quick takeaway.
I see a lot of potential here in Uganda. I don't know. That's the feeling that was coming to me as we were closing. And I appreciate the opportunity to be here on this panel and to have this conversation. But um, in my conversations with Jamiru and Paul Mbaka, it seems like the ministry is wanting to really catalyze a local ecosystem. And I think there are a lot of stakeholders in the audience that have been looking for the opportunity to engage with that ecosystem in different ways. And so um, I always say, and people know me for saying this, I say, never let a good crisis go to waste. And some people look at what has happened over the past few months as a bit of a crisis, but I see crisis as a moment where people are more open to change. And I think it's very safe to say, I think, and I hope this doesn't come across the wrong way, it's not as if the previous model was working exceptionally well. It had its own faults and challenges. And so I do think that this is an opportunity. The ministry has strong emerging leadership, and it's an opportunity to create an ecosystem of their desire. And there's a lot of foundational pieces there. It's just a matter of being clear about what the expectations are for each of the partners. And I think the rest will kind of evolve naturally.
Thanks. And Jonathan?
Support reduces. We want to advocate and promote the use of a community. And OpenMRS community is a living example. Together we share the same problems and come up with solutions. So as we promote the implementation of digital health, we need to support one another and we shall make change happen.
Ladies and gentlemen, can we appreciate our panelists? I'll request you be upstanding for our photo. We'll have a panelists photo. This is very important as a particular session of the conference. And so we want to appreciate you. So ladies and gentlemen, can we once more appreciate our panelists? Thank you, Jonathan. Thank you, Paul. Thank you, Jamir and Kenneth, for insights shared in this conversation. I want to request our team that is responsible for the next activity. I'm sure you're aware we've seen a bit of movement on this end. So I want to ask the team to make their way as we invite Nyange Cultural Troupe to entertain us as we prepare to cut this cake. Nyange? Thank you, Nyange. Thank you so much. Can we appreciate Nyange, ladies and gentlemen? And all our partners, our sponsors. Sponsors, please come. Mets, we have, of course, Arcstute and SIL. Please come and invite CDC to join us. Please come. So they will represent all of us as we celebrate this moment. And I know Dr. Alice is saying, you know, we can host you again next year. He doesn't have to go anywhere else. We can do this again. So we want to do things a bit differently so that you come back. Jamir, I had seen him. Yes, yes, please come. Uh, what happened to Paul Mbaka? He's on the system. Is checking. He's on the firewall. All right. All right. We have everyone here. We just need to make sure. So we'll count. And if you're with us virtually, you're going to miss a taste of what is truly Ugandan cake. So we'll count from 5. All right. Or it could have been 16, since this is the 16th implementers conference. So let's get closer. And the knife, there you go. So 5, Paul, you need to touch someone who's holding the knife. There you go. 5, 4, 3, 2, 1, and 0. Thank you very much. We are still trying to study how these poppers work. We're still studying this. Thank you so much. Feel free to take your seats. Team, we want a taste of this. But as we do this, we want to transition very quickly into the next session as cake is coming to you. So I'm requesting we continue the conversation we are having. So we're going to the Unconference voting. So can we, and I just need to check my program. Is that Jeremy I should be inviting to handle this? And then we can continue to have a working tea or coffee a bit later. But allow me request that we transition to the next session, and I'll invite Jabbar, Jeremy to come, and I can see that testing the system to ensure that it is actually working. So we want to move quickly to link to the Unconference Planning Board and the voting session. Yes, I see the team is set at the back. Please come. You will drive this conversation, and immediately after that, we'll do the health break, and then, of course, all the other activities, including the Birds of Feather optional part of the program that is coming up a little later, is on the app and on the conference agenda. So please look that up as cake continues to come. Jabbar.
Oh, hi everyone. Welcome to this section of so yes, we call this section of the conference unconferencing. So basically what we're going to do, we are going to choose topics of our own that we expect to see in our next conference, or we expect OpenMRS to probably do for us within a year or so. So we are going to basically provide you with a couple of sticky notes. And I think we all have pens on our desks. So we're going to basically write and basically 10 minutes to write, and then we shall vote against those topics that you would expect to see.
Yeah.
Yeah.
So this conference is your conference, right,
Exactly.
Chaba? So you decide how to move forward from now on, because now you can propose your topics. This is your time to propose your topics, and we will discuss about those topics in upcoming days,
Yes.
right, Chaba? So so now you will be given all the sticky notes as Chaba mentioned. Beryl, can we have those sticky notes?
Well,
Yeah, you'll get in a while. So you will have 10 minutes, right?
yeah, we have 10 minutes, each one of us, to choose a topic.
Mhm.
After choosing a topic, we'll have ourselves vote against them. So you'll
Yeah.
come to the board to vote on the topic that you think is more priority to you as an implementer or as an individual from the OpenMRS community, right?
Yeah.
Yeah.
So at the end of that 10 minutes, so we'll put a timer and you will see a board. So you can like paste them, like we'll bring the board here. And after that, you have 15 minutes just to do the voting. You have your pens and come to front and just like put a tick on the topics that you like to see in the upcoming few days you would like to discuss. And yeah, then we will pick the top voted topics, and we will organize the breakout rooms for this next several days. There will be a lead, and you can just like have the conversation ongoing on the upcoming days.
Yeah, yeah. So you're not limited to the topic, so think of anything, please. Yeah.
Exactly, yes. So we will provide the sticky notes. The timer will start in next few minutes. So yeah.
Let's get the sticky notes. Is it connected? Hmm? Is it connected?
Yes. Okay, so I hope you everyone received the sticky note. So this is your time. So your timer will start now. You have 10 minutes to propose topics.